A very good morning to all the delegates who have joined with us today on this amazing platform of CECCRe 3.0, the third annual National Conference on Early Childhood Caries. I welcome you all to the lecture on bite force. We all understand that when the maxillary and mandibular teeth are glued, or in other terms, when the child clenches, there is an amount of force generated within the stomatognathig system. When it is at its peak, it's called as maximum voluntary bite force. Now, this force is used to perform some routine functions such as mastication, speech, and also maintain the balance within the oral cavity. Thus, the force generated within the oral cavity is important and also to be monitored. However, in order to do this, that is to monitor the forces generated within the oral cavity, one should know what is the normal force that can be generated within the child. What is the average force generated? What is an above average force, etc. Does the literature give us this data? Yes, but unfortunately the literature gives us too much data. There are multiple studies and multiple reports on bite force in children. Also, multiple methods have been reported in the literature to record the same. And as you can rightly predict, this leads to multiple average bite force values generated from all the available data. Thus, our team got together and performed a systematic review and meta-analysis to collate all the data available in the literature in children to understand what is indeed the average maximum voluntary bite force. I am Dr. Priya Jayakumar, Assistant Professor from the Department of Pediatric and Preventive Dentistry, CECCRe, Sri Ramachandra Dental College and Hospitals, here to tell you the numbers pertaining to the bite force measurements in primary dentition. Quantifying biting pressure or biting force will serve as an index for assessment of the level of normality or deviation from the normal in oral health in children when clinical complications such as dental decay, temporomandibular joint disorders or muscle disorders, malocclusion, or even early loss of primary teeth occurs. Although there are earlier reports, like I mentioned, on maximum voluntary bite force and bite force measuring devices, the unlimited data leads to an uncertainty regarding the calibrated values measured in children and adolescents. Thus, there exists a strong need for evaluation of the available evidence, which is what this review primarily intended to do: compile bite force measurements in children and adolescents systematically. Now, moving on to the materials and methods. The study was performed according to the PRISMA guidelines, and we began by registering our protocol with Prospero. Search strategy was formulated with the mesh terms and was subjected to search with 4 databases, namely PubMed, Cochrane, Lilacs, and Embase. Also, hand searching of 8 other journals, cross-references, and related grey literature was also done to gather literature. Now, moving on to the inclusion and exclusion criteria of the study. Children and adolescents comprise the study population. This systematic review included observational studies, that is cross-sectional, case control, and cohort studies. Also, experimental studies evaluating maximum voluntary bite force using a bite force measuring device was also included. Study designs such as reviews, protocols for trials, and conference abstracts were excluded. Any study that measured maximum voluntary bite force in children were included, and any study that measured maximum voluntary bite force in adults were excluded. Children with special healthcare needs and medically compromised patients were also excluded. Studies reporting only in English language was included for the review. reviewers did data collection independently through an initial title and abstract screening. Consensus was sought from a third review in case of disagreements. All studies excluded at this point were documented in Excel sheets. The two authors extracted data independently from each included study, and further information was sought from either the corresponding or the primary author whenever there was insufficient data in the publication. For all the included studies, risk of bias was assessed using the Newcastle-Ottawa scale for cohort and case control studies, while the modified Newcastle-Ottawa scale was used for the cross-sectional studies. The risk of bias was designed in a manner to be scored as high when they obtained more than 7 stars, moderate when the study obtained 5 to 6 stars, and low when they obtained less than 5 stars using the NOS and modified NOS scales. Also, the clinical trials was assessed using the Robinson tool. Statistical analysis was performed. Studies that reported average maximum voluntary bite force values and standard deviation were categorized into primary, mixed and permanent dentitions. However, the results of only primary dentition will be presented today. The data was pooled for meta-analysis utilizing the R software metaphor package. Forest plots were generated for parameters of concern to represent the estimated effect of mean bite force across dentitions. Subgroup analysis was done for bite force values based on gender, site, measuring devices, as well as ethnicity. Random effects model measured the average differences in the investigated outcome. The statistical heterogeneity was estimated by the chi-square test and the I-square test. Moving on to the results of the study. This is the Prisma flowchart depicting the total number of included studies in this review. An initial search from all the databases led to a total of 614 articles to be generated, and as exclusion criteria progressed at every stage due to duplication or not matching the inclusion criteria of the study, finally 61 studies were included in this review. Publications dated from 1986 to 2022 were included in this review. Study designs were divided into cohort 2 studies, case control 1 study, cross-sectional maximum of 48, and clinical trials 10 were included in this review. Of the data points extracted, 22 unique world regions were identified with the largest contributions from Brazil, Japan, and Jordan. Ages ranged from 3 to 19 years, with a total of 8,864 included participants. We will be discussing about the studies that contributed to bite force assessment in primary dentition alone next. The majority of the included studies had a low risk of bias, moderate in 16 publications, high risk of bias reported in 4 included articles based on the NOS and modified NOS scales. Among the 10 clinical trials, based on the Robbins I tool, 7 studies had critical risk and 3 had serious risk. Of the 13 studies included for quantitative synthesis, 12 studies contributed for computing maximum voluntary bite force in the primary dentition. The average bite force contributed to 246.22 newtons from 2,155 children. For the gender assessment, the molar bite force reported from 751 boys averaged to 222.30 newtons. This showed a slight increase in bite force values when compared to the bite force values obtained from 759 girls, which was 202.43 newtons. The average bite force values when compared with the right and the left side range from 169.79 newtons on the right and 163.88 newtons on the left. From the results of this review, we understand that the males had a slight increase or a slightly more biting pressure than the females in the age group of 3 to 6 years. And this finding is consistent with the interpretations of other authors such as Abu Elijah and Palinkas. Also, when comparing the sides, the right side had a greater bite force than the left, and the reasons for this needs further intervention. A total of 11 different recording devices were categorized in this review, of which the portable occlusal bite force gauge was the most commonly used device. This review provides you with the highest possible evidence available on maximum voluntary bite force. Also, the absence of time limit renders this review robust. Multiple factors that influence bite force have been addressed in this review, such as site, side, also gender. The other factors that influence bite force and accuracy of the apparatus used for recording bite force were not included, and this could be considered as a limitation of this study. Also, one other limitation is that the majority of the included studies were of the cross-sectional design. I would like to conclude by saying the maximum bite force averaged to 246.22 newtons in children between the age groups of 3 and 6. The portable occlusal bite force gauge or meter was the most commonly used device, as it was very convenient and easily portable in children. Bite force or occlusion is a transition process, hence it keeps changing. Therefore, it needs continuous monitoring to be applicable clinically. With that, I thank the organizers for giving me this platform to present data of my study, and if there are any queries, kindly contact this email ID. Thank you one and all for joining me here today.